Okay, I'll start with you today.
Okay, I hope people can see a scanned radiograph
We can.
from the late 90s, showing a sort of junky looking lung bases down here, some little nodules and lines down here in the right base, some bronchial wall thickening with a nice radial arrangement here. So it looks as if there's probably something associated with airways given this bronchial wall thickening. Blunting of the left costophrenic angle by solid pleural thickening, it turns out. Heart size normal. And then here's a scanned CT from that era. So as we go through the mediastinum, there's not much in the way of lymphadenopathy, little dilation of the esophagus. And then we get to a lung window here. I don't have that many cuts to show you guys, but here's what we've got. So there's some mosaic attenuation and some thickened bronchial walls and some little dots here, central lobular dots corresponding to bronchiolitis. So this person has bronchiolitis concentrated in mid-lungs and bases, large airways disease in terms of bronchial wall thickening and mild ectasia, and probably some bronchiolar dysfunction. Conducting bronchioles are not working well here because we have the attenuation, presumed air trapping. So lots of basal predominant bronchial and bronchiolar disease. This person was put on erythromycin, and years later, that was 99 that we're looking at, and now we're up to, I think, 2015. This person felt much better on erythromycin therapy, which he continues to be on. We still see that there is a persisting bronchial abnormality. The small airways shadows have pretty much gone away, but we do have some mild basal predominant bronchiectasis. And this was a man of Japanese descent. I think he was actually born in Japan. And, extensive workup didn't reveal anything they could really pin down. And this is considered to be Asian panbronchiolitis, which is most common in Japanese and secondly in Koreans. And it probably reflects a particular, I'm just reading about this in Wikipedia, some HLA particular mutations that are common in those Asian populations that predispose to an inflammatory response to probably ordinary bugs. So nothing specific in the bacteriology of this condition, but it's probably a combination of environment in terms of bacteria and viruses interacting with particular HLA phenotypes. So Asian panbronchiolitis, one of the few cases I've seen.
David, do they have to stay on macrolide suppression, or does it recur if they stop the erythromycin?
I think that it can recur. So I don't know the answer to that question in detail. We'd have to, I can consult with pulmonologists who be taking care of them. So it used to be called diffuse panbronchiolitis. It was named by Japanese people back in the 60s. And now it's called Asian panbronchiolitis. Okay. So here's another set of junky looking lungs. In this case, there are all these little dots and they seem to be concentrated in mid and upper lungs. Heart size okay. Lateral view, again, it's concentrated in mid and upper lungs. It's small dots. Here's what it looks like on CT. A ton of small dots. Central lobular distribution. A lot of edge enhancement artifact out here on this outside scan, but the little dots seem to spare that immediately subpleural region. So it seems to be an airways distribution. And it's nicely brought out on MIPS. Just a ton of little central lobular dots here. Let's go back to conventional CT. Some modest lymphadenopathy here, not too great. Smudgy, not very well defined. So this is diffuse airways disease. Here, small airways disease, and this is a great pattern for hypersensitivity pneumonitis. So it turns out that this fellow worked in the seafood industry, and his job was to put the fish in position so the machine could do the filleting. So he wasn't scraping the fish himself, but this is presumed to be an antigen here to a fish antigen. I've shown a case before in this conference a few years ago of somebody who was a fish scaler who worked on one of the factory trawlers that was harvesting fish off the Alaska coast and stuff like that. So here's another case of fish antigen hypersensitivity pneumonitis, and I think the nice distribution in the upper lungs goes nicely for hypersensitivity pneumonitis. Here's shown here on these coronal views. So very short of breath when exposed to fish. And then I think his symptoms recurred when he'd left the industry, but his symptoms recurred when he went fishing. So it's probably, again, another element in establishing that this is fish antigen hypersensitivity pneumonitis.
David, these nodules are a little more well defined than I'm used to seeing with HP.
Right. And I've seen those in a couple of other conditions. So it can occur. I think probably eventually you probably get some tiny little mucus plugs or something like that, something that's firmer and crisper or something like that. So I've seen it in people whose symptoms have gone on for a long time. So it's in the range, but to me it suggests chronicity.
Makes sense.
So a couple of plain radiographs to show you. This person had this baseline radiograph back in May with pacemaker electrodes in this position, and then had a change of catheter. So they took out the right arm catheter, the PIC, and they put in this right jugular catheter, and it went down here. And in doing so, they displaced this atrial electrode. So you can see it's slightly lower here than it was before. And on lateral view, you can see that it's changed position quite a bit. So it's dropped down from this higher position to the same position as the ventricular electrode here. So this was displacement of a atrial electrode by the right jugular catheter placement. So that's a cute little plain film odyssey. And then here's another plain film odyssey. We had this big heat wave in Seattle about 10 days ago. Temperatures got up to 108, which is really unprecedented. And so a lot of people were brought in. There were 13 deaths in King County attributed to heat, and there are probably many more. This person was brought in with unresponsive with a temperature of 103. And she has pre-existing conditions here. She's an elderly woman, I think 90 some, and she's got a lot of lung disease. She does have a pneumothorax up here. I'm not going to show you the CT. So there's a chronic pneumothorax with this drain in place, and there's a lot of lung consolidation and cavitation here. So there's pre-existing stuff. But the interesting finding for this current admission here, it's different from her previous findings, is this ice pack here on her arm. So when they treat hyperthermia, they usually put the ice packs on the periphery. So they put them on the arms or wrists. And this person has ice pack here on the left arm. So that's what we're seeing here. All this lumpy stuff are ice cubes in a bag. So I showed a case last week or the week before of another patient with hyperthermia admitted on the same weekend. And that person actually had ice chips all over the chest, but they tend not to do that. One of the things you don't want to do is to generate so much vasoconstriction in the skin by cooling it too much that you actually prevent heat loss. You prevent blood flow to the skin to shed the heat. So that's why they tend to be careful in placing the ice cubes and things like that, sort of away from the central part of the body. So this one is a typical location by putting the ice cubes on the arm. Treatment of hyperthermia. Okay, and hyperthermia killed the previous patient, the one I showed you, by causing cardiac dysfunction. So it's typically cardiac or respiratory dysfunction that is the lethal event triggered by hyperthermia. I thought that was a cool case. Get it? Cool? Okay. Okay, this person has an abnormal chest radiograph. You can see mostly upper lung disease here with some bronchial wall thickening and maybe some radial bronchial shadows again here. So mostly mid and upper lung disease. This is back from 2014. Here's what CT looked like in that era. You can see there's a lot of peribronchial consolidation here, inflammation, and some dilation of these upper lung bronchi. So bronchiectasis and peribronchial inflammation, and then some peribronchiolar, probably infections, some mucus plugs perhaps, and then quite a bit here of mosaic and associated bronchial disease. So this is probably a lot of air trapping here caused by the actual small airways disease. We're seeing the large airways disease here in terms of bronchi, thick and dilated bronchi, but the small airways disease is what's causing this air trapping. That's actually what makes people dyspneic. So lots of airways disease. This is chronic. This is a young person, I think in his 20s at this point, and around this time he was transitioned in his care from our children's hospital to adult medicine people, and so there was a burst of imaging around 2013. So with time, things got worse, and you can see here's a current image on this person. Lots more scarring and deformity in upper lungs. The hyla are being pulled upward. We're starting to get juxtaphrenic peaks along the diaphragm. So lots of distortion. And on CT, current CT here, we just have a ton of peribronchial consolidation, traction bronchiectasis. And then again, the hypoattenuation of vessels here, so lots of air trapping causing this rarefaction in the lung bases. And you can see the origin of the juxtaphrenic peak in terms of traction on these accessory fissures pulling up little folds off the diaphragm of extrapleural fat. Okay, and Jeff, this person has all these little dots here of BPO in association with this chronic lung scarring.
Oh,
so anytime you get scar, you can get some ossification along with the fibrous tissue. So probably some of the fibroblasts turn into osteoblasts and start laying down little spicules of bone. So anytime there's scarring, you can also get bone formation in the lung. It's not exclusive to any kind of lung scarring. It occurs with UIP, but it can occur with other lung scars. So this person has a kind of immune deficiency. This is a pretty rare one. This is ataxia telangiectasia. I'm not sure I've seen any other cases of this. I remember, learning a little bit about this in the old days back in pediatric rotations and stuff like that. So they do have ataxia and they get telangiectasias, and it turns out they also have immune deficiency. So it's a chromosomal abnormality. It is autosomal recessive trait. And this fellow has actually been managed pretty well, but he's got a lot of lung disease. And I think it's only his youth that permits him to be relatively asymptomatic and pretty well controlled. But I think eventually he's probably going to need a lung transplant. So it's both a humoral and a cellular immune deficiency associated with this ataxia telangiectasia. Has anybody else seen a case in adults?
No.
Nope. This is my first. Okay, so those are my cases.
Thank you, David. Always cool stuff. All right, Howard, do you have cases?
Okay.
All right.
Let me show you this one, which is one I showed last week, just by way of introduction. This is a patient with the unilateral lung edema. You see the asymmetry on CT, and particularly see the amount of lung edema in the right upper lobe compared to the other lobes of the lungs. and pleural fluid. So a very nice example of the asymmetric, particularly right upper lobe edema that one can see with mitral valve regurgitation. Well, unusual things sometimes happen sort of in pairs. Here is a patient that I was asked to look at. There is a remote history, not recent, of breast cancer. The patient is still being treated with an agent, but I can't remember what it is. But the history of the breast cancer and the treatment of it primarily goes back quite a few years. So that's chest radiography. We can see clearly asymmetric and extensive right lung disease. Let's look at the CT. And we begin already here to see the asymmetry of the amount of consolidation, particularly in the right upper lobe. But there is also interstitial edema as well, and that's also asymmetric. So asymmetric interstitial edema, septal lines, peribronchial fluid cuffs, subpleural edema related to the interlobar fissure, and asymmetric amount of right pleural fluid. That persisted over time. So this is the 14th. They imaged the patient again on the 20th, and the same findings are present, perhaps even more alveolar edema, and yes, an increase in the amount of pleural fluid. So another patient with mitral valve disease. This is the TEE, confirming the diagnosis, prolapse of the entire P2 segment of mitral valve with flail cord and severe mitral regurgitation. And they fixed that, put in a annuloplasty and also the tricuspid repair, and at the same time they did some surgery for the left atrium and a maze procedure as well. But another case of really textbook typical asymmetric and right upper lobe edema from mitral valve regurgitation. Let me just remind myself what she looked like. That's not right, post-op, if I can fix that. No, that's still pre-op, but this patient had surgery as well. So two relatively unusual things in short order. Here is a patient with chest radiography that's like this. So we have marked cardiomegaly, and we have dilatation of pulmonary vessels. I'm going to bring this coronal slab to the side here. And sorry about that. Let me try and fix that. When I teach about pulmonary hypertension and I ask residents to tell me what they see in relation to the pulmonary vessels, we want to identify a number of things. Yes, the vessels are distended, but the next question is, are we seeing just distended pulmonary arteries, or are we also seeing distended pulmonary veins? In terms of the distribution of pulmonary blood flow in the context of pulmonary hypertension, I particularly want to know whether they think, for example, there is inversion of pulmonary blood flow, a consequence of chronic pulmonary venous hypertension, or whether the vessels are distended everywhere and about equally, the so-called balanced distribution of pulmonary blood flow. And then in trying to distinguish between distended pulmonary arteries and veins, it of course can be hard because they overlap or may overlap substantially. But if you do see two vessels that parallel each other, for example, here's one, here's the other, this one ought to be a distended superior pulmonary vein, and the medial one, the artery. Now, of course, that isn't always the case. You can't always separate them out that way. But for example, if this is a distended left superior pulmonary vein, then do we see a corresponding distended right superior pulmonary vein? Hard to say. But if we're thinking that we have distended vessels, arteries and veins, and a balanced distribution of pulmonary blood flow, then we should be thinking of a left to right shunt chronic as the cause of the pulmonary hypertension. So here me show you the CT, and I'm going to show you the reason why on the CT we do not see a counterpart to the distended left superior pulmonary vein. So if we look at the atrium and we look for veins, big, left superior, right, left inferior, right inferior. When we go up here to look for the distended superior pulmonary vein, we don't see it, and that's because we have a communication between pulmonary veins in two locations and the superior vena cava. So we have a PAPVR involving the right upper lobe. Hence we have and should have an ASD, but a superior sinus venosus type of ASD, which we have here. So this is pulmonary hypertension from a shunt. And here is an excerpt of the surgery of the condition. You can see that there were two large veins entering the SVC with the two smaller veins entering higher up. So the two smaller veins are up here and the slightly larger ones are here that correspond with that observation. And they did a Warden procedure to correct that. So basically you reroute the pulmonary veins back to the left atrium, you separate the superior vena cava and the inferior vena cava and then connect them again to fix that condition. So a nice example of pulmonary hypertension from that condition. Here's a nice pre-op and a post-op in a patient with this pectus carinatum deformity. It's a pre-op CT. You can see the rather focal, rather severe pectus carinatum deformity. And I'm going to put alongside the frontal projection after corrective surgery. So we can see we have plates, two of them in the sternum, and we have another one down here. Here is the lateral projection. We can see a nice flat sternum. We can see the two plates, and then we can see this bar that is placed as well for this procedure. So there are different procedures one can do for that. Similar kind of procedure can be done for a pectus excavatum, of course. But this one over here, and I'll just leave this up there so you can read that, but it's called a modified ravage procedure. In this particular person, it involved, by virtue of the deformity, two sternal incisions. They resect a bunch of costal cartilage on both sides, and they basically go ahead and fix that up. So I'll leave that up for you if you view the video, just to read that procedure. So it's called a modified ravage procedure for correction of pectus carinatum. And I think, but I'm not sure, that this procedure may be the one that's most frequently done for that condition.
So
that
Howard,
bar,
like they,
that was more like a noose bar.
Yeah.
NUSS.
Yeah.
That was the other bar. So the ravage procedures I've seen before usually had a different transverse horizontal bar than this one. So
yeah, they just called it a pectus bar. So they did all that stuff. There's a blue plate, 16-hole plate that was cut in half for 2 8-holes. And then they did put the pectus bar in as well for this procedure.
Got it.
And shape that. Yeah, you're right. Oh yeah. Okay, so a couple months ago now, a nice case was shown, and I didn't recognize it. A bunch of us, I think, if I remember correctly, hadn't seen it, of what turned out to be, David, you showed this, the coral reef aorta. And that one that you showed, I think, had the findings in both the lower thoracic and the abdominal aorta, if I remember correctly. And I showed it to one of my colleagues in abdominal imaging. And sure enough, this is how way things work. A couple months later, sent me this case. And here's another one involving the abdominal aorta. So imaging findings right there, very typical now that I recognize it. Coral reef abdominal aorta, a lot of atherosclerosis. So another nice case of that.
So evidently, the abdominal aorta is most common, and the thoracic
Okay.
is much less common. So
Okay.
this is evidently more typical. But for me, this is now N of 2. So you've doubled my experience.
Yeah. So seen a couple cases all of a sudden. Let's see. That one was the
It was
and
Travis, by the way, who made the diagnosis of coral reef.
yeah, exactly. Yeah, I hadn't seen that before. This is a patient that is post-op and had cardiothoracic surgery. I'm trying to remember if it was a cabbage or something to do with the aorta, but I can't quite remember. After surgery, didn't do well, as you can see here. Diffuse bilateral lung consolidation, which on BAL turned out to have features of blood. So this is diffuse pulmonary hemorrhage. I don't know why this patient experienced this perioperative complication. But when I was looking at these images, I noticed that, let's see if I can bring this one up, or maybe this one shows it best, that this patient has 2 cannulae in the here IVC to suprahepatic IVC, and then a second one that terminates more superiorly in the right atrium and SVC. So this is for veno-venous ECMO. Usually I see that here in the context of a single jugular cannula with 2 channels for veno-venous ECMO. But this is the way that veno-venous ECMO can be done with this kind of anatomy. Of course, if you do have 2 cannulae like that, they need to be separated so that the blood doesn't just go directly from one to the other, which this one is. So that's the diagram. I don't know why in this person they've used this method for veno-venous ECMO, but that's an example of it. So a 2 cannula veno-venous ECMO setup in this particular patient. And that explains why we have 2 cannulae in the IVC and right atrium SVC that we see there.
So Howard, explain what the goal of this is. What are we doing basically here with these cannulae?
We're just basically oxygenating blood to deal with the acute respiratory failure caused by the lung disease. So there's no circulatory support, but just basically oxygenation.
Okay.
In this particular person. We've seen it most frequently, of course, nowadays in the context of severe COVID-19 pneumonia, but of course, any cause of severe acute respiratory failure.
Howard, was he put on ECMO because of the hemorrhage?
Because of the.
A lot of times I see a lot of consolidation in the lungs in these patients on VV ECMO. And sometimes I think it's just from just congestion. Just the lungs just get very congested.
I don't know. I think this person definitely has diffuse consolidation preceding the venous ECMO. So for that reason. but I'm still perplexed as to why this patient has been diagnosed with diffuse pulmonary hemorrhage as a post-op cardiac patient. I don't know what happened or why that's the case. Those are my cases, Jeff.
Thank you, Howard. Peter, are you available to show cases?
Yeah, I can show. I know I've been out for a while, but
Are you logged in as Emory Chest?
yeah, I'm in our reading room.
Sure. No problem. All right, there we go.
All right, can you guys see the screen?
Yep.
Okay, so I'll start off with this case. This is one of Art Stillman's cases that he showed me. So it's kind of a quick case, but here's the abnormality. So this is we think this is a fibrous cord of the aorta, which is just a kind of a congenital remnant, and it looks like obviously it looks like a little dissection there, but I think it's just a congenital abnormality that's asymptomatic. I don't remember this patient's asymptomatic, and this was just an incidental finding. There was no I'm not sure what the reason for the scan was, but it wasn't this wasn't what it was indicated. Here's a small article on this entity, and the speculation is that it's related to the fifth primitive aortic arch remnant there. And then they show some images.
Wow, I've never seen that before. It's so interesting.
So they only occur right there.
Yeah, have you seen that before,
No,
Jeff?
never heard of it.
Never heard of it, never seen it.
I hadn't either.
Must be pretty darn rare. That's cool.
But it doesn't really look like a dissection, right? Would you
No,
agree with that?
because it's not really a
It has that.
it's really a cord, like you said.
Yeah, it looks kind of like a cord. Exactly.
Gosh.
That is really neat.
Probably going to see in a second next week. Just wait.
Yeah. Looking back, I remember seeing something like this in the past, and I wasn't sure what it was, but that's probably what it was. I was hesitant to call something like that a dissection before. Okay, a few more. This is a quick one. This patient has a renal transplant. You guys have any guesses on what's going on in the right lower lobe?
Renal transplant. Patient immunocompromised in the context of renal transplantation?
Yeah. This is one of the more common things I guess we've shown.
No cardia.
No, but you're on the right track.
Actually, looks like something aspirated. So how about actino?
No, cryptococcus.
Cryptococcus. Well-defined blobs.
Yeah, so I'm assuming this is granulomatous, and it looks you can see it kind of tracking up the bronchovascular bundle there. So granulomatous, but much larger granulomas than we usually see with histo, which has kind of the same kind of rays of round nodules tracking up, but no calcification here, and much larger.
I saw the subcarinal node was big. Is there a big hilar node?
I don't know with crypto if you usually get.
My experience, no. It was like histo, you tend to get like disproportionate.
Yeah, with histo, and then we check the spleen, of course. Yeah, I think. Yeah, right next to the esophagus.
Yeah, not huge, but
which makes sense because this is where these would drain right there.
Well, that's a great example. Yeah, I mean, when I see big, round, smooth nodules in immunosuppressed patients, I always think of crypto, and they're often necrotic, and they can cavitate.
Yeah.
Low attenuation in the middle.
Now they talk about crypto can show up as nodules, but then also as just all other kinds of stuff like consolidations.
Small nodules.
Small nodules. So very, so I guess
you're right. You don't typically see histo like big blobs like this, especially in immune compromised patients. They're more likely to have disseminated disease and miliary.
Yeah, much smaller ones, and then I've seen a few histos already this week.
That's a good thing.
Okay. So this one is a vascular case. Another quick one. This patient is in her early 30s and she's postpartum. She has Marfan's disease. And here's her scan 2 days postpartum. Very obviously a huge aortic root here, which should be repaired in a Marfan's patient. She had chest pain at the time of the scan. That's why she was scanned. But I don't think I would call anything on this. But here's her scan 2 days later. So here are the dates, 24th and 4 days later, actually. So here you can see a dissection right there that is hard to, a little bit hard to see with the motion at the root, but it's definitely dissected right there. And I suspect there was probably something on this initial scan, maybe this line here, but it's right where the sinus of Valsalva is, so it would be, I don't think I would call anything on that. Yeah, and this was confirmed that she was she had her aortic root replaced. So subtle dissection at the root.
So it's just limited to right there, huh?
Right there, yeah. But I'm assuming if this was left, it would progress.
Right, for sure.
Progress up.
So this may be the variant of so-called limited aortic dissection or incomplete or limited aortic dissection, because it seems to be just there.
Yeah.
With incomplete dissection, one doesn't see an intermedial flap as such.
Yeah.
It's just a luminal irregularity, sometimes looking like a little mushroom. But yours, we do see a flap, I believe, yeah.
Now the only thing with the limited, my what I just recall reading about them is that they're kind of clinically insignificant and they don't do much about them. But this one was obviously significant. The patient was having severe chest pain. So from a clinical standpoint, I don't know if they consider this limited, you know. But yeah, morphologically it looks just like a line. Okay, and then I have two cardiac masses. One is a revisiting of the case I showed back in May. It was a while ago, so I'm sure I'll just show the images again. But this is a young lady in her early 30s, and then this cardiac mass was found incidentally in an abdominal MRI. So then that warranted cardiac imaging. So this is the SSFP, and very low signal on that. T1, the low signal again. T2, intermediate or heterogeneous, but fairly low signal. Another T1 low. T2 low signal. This is the breast perfusion. So you can see it. It enhances on first pass. And then axial vibe, which is just a post contrast. T1, you can see avid enhancement, diffuse enhancement, and then delayed enhancement, homogeneous enhancement. We have the path. So this is the fibroma here, and this is, for reference, this is normal myocardium. You can see multiple nuclei, and then here in the fibroma, you can see the kind of the fibrous, the collagen tissue, just with fairly acellular and just infiltration of fibrous tissue. And here's the margin. So here is the, so you can see the mass right there. It's mobile, and it looks like it's attached to the chordae tendineae of the mitral valve. I didn't show the delayed images because they were kind of poor quality, but here's what it looks like on CT. So not hard to overlook on CT just because it's right where the PAP muscles are coming in, but it's right there. This patient, I forgot to mention, presented with strokes, so that's why he had a cardiac workup to look for thrombus. But we didn't find thrombus. We found this mass, and this mass was, we call it most likely a papillary fibrosarcoma, and that's what it was taken out. That's what it was, and I have the path for that too. Yeah. So here we see these arborizing fronds. Sometimes you can go. Which kind of classic look for fibrosarcoma. So these fronds, and then they have a single layer of myocardium, and you can see it here, and then essentially you just have fibroelastic tissue.
Very nice.
And here's one more image of it. I guess it's endocardium, myocardium lining, and then just the acellular fibroelastic tissue.
Do pieces break off, or does a bit of clot form that potentially embolizes?
Yeah, pieces can break off and embolize and cause strokes, and that's what was happening in this case. Yep.
Oh, okay.
And that's, I think I covered it. I have it. Those are all I had.
Great, awesome cases. Thank you.
Thanks, guys.
All right. I have 3 cases I can share. So this first case is a patient who has non-small cell lung carcinoma that's being metastatic, involving brain and I think bone, and has been getting chemotherapy with carboplatin and pemetrexed, and got 1 dose of pembrolizumab, and was also on a steroid taper for intracranial metastases, which were being treated with radiosurgery. And he presented with shortness of breath and cough and just not feeling well. And this was his initial chest radiograph. And you can see there's the mass, the primary lung cancer, but there's this just diffuse hazy abnormality in both lungs and maybe some nodules. And so thought was maybe a drug reaction or something, but he'd only had 1 dose of pembrolizumab. We see a lot of pembrolizumab-induced lung injury. Let's see. So here was the CT scan for the same day. He had pulmonary embolism, but that was secondary finding here. But you can see there's this just sort of patchy ground glass opacity. There's the cancer. There's some mets on this background of emphysema. It's bilateral. Some areas have what looks like an organizing pneumonia appearance with this perilobular outlining, arcading along there, but sort of affecting both lungs fairly equally. And so he was admitted and put on broad spectrum antibiotics, but wasn't getting better, and the usual workup began. So here's his next radiograph, and you can see he got quite worse rather quickly and is developing this diffuse lung abnormality. Then here is the one 2 days later, and it's kind of holding out at this point, becoming a little bit more confluent. So they actually did sputum and didn't find any organisms but they did run a PCR for a bunch of things, respiratory virus tests and everything. But what came back was a positive PCR for pneumocystis. So this is, we don't see pneumocystis very much in our chemotherapy patients. I suspect the steroids contributed because he was on quite a bit for, it looked like about 3 or 4 weeks, which is enough time. It's a little unusual in that it was a more nodular appearance. It was a little bit more lower lobe predominant. I think a lot of these nodules, though, pertain to his tumor. I don't have any earlier imaging. He wasn't normally one of our patients, so I don't have what he looked like baseline treatment time. But just an unusual population to see pneumocystis. Mostly we see it in our transplant patients sometimes when they're off prophylaxis, or in patients with undiagnosed HIV. Okay. Yeah, just a little different. This is an odd case. Go ahead.
Was that on BAL PCR or
sputum?
Oh, sputum?
Yeah, I looked for a bronch. They didn't bronch him, so they got a good sputum. He was coughing up stuff, so they ran a PCR on it.
Okay.
I'll be curious what you guys think about this case. It's very interesting. So this is a middle-aged female who back at the time of her presentation presented with cough and shortness of breath and had a CT that looked like this. And there are these very discrete areas of ground glass opacity. Many of them conform to lobules. It sort of was mid and lower lung predominant, but had these little striking interfaces with absolutely normal lung. And at the time, she had a peripheral eosinophilia, and so was diagnosed with an eosinophilic lung disease, cause unknown, and treated with steroids and felt better. And I came across her on a follow-up scan, so that this was like 10 years later. And she's been, at this point, feeling fine, been off steroids. But what was interesting is these ground glass areas persisted. Many of them did. Some got better. But there's these small cystic spaces in a bunch of them. And they're only where the ground glass is, so it's not like some other process going on. And I've not seen an eosinophilic pneumonia persist over time. And I mean, honestly, I would expect her to have symptoms or something from this, but and she not on steroids. So, and I don't know if she's developed a little fibrosis from this. I mean, there's some dilated airways down here or not. But have any of you ever seen a long-standing eosinophilic process like this that develops cystic spaces? I'm not happy with that diagnosis.
No, do you think this changes could be just bronchiectasis, like traction?
Well, that's what it was just all traction bronchiectasis. What I was trying to sort out is why, usually eosinophilic pneumonia is
different on the prior.
Yeah, I mean, usually eosinophilic pneumonias just melt away. Oh, I thought I'd separated these. When you, that's weird.
Command G.
There we go. Thank you, Howard. You can see it. So here we're at the inferior pulmonary vein. And like, for example, these two patchy areas, the ground glass was there before. These are 10 years apart, but now it's more cystic.
Can you zoom in a bit, Jeff? That's odd.
I think there's a little volume loss there.
Yeah, I mean, but everything seems to line up pretty well here. I mean, maybe a little retraction. So I wonder if it did fibrose, and maybe these are dilated airways. It's just odd. Very odd. Yeah, they never did anything. They never biopsied anything. So I don't know what was going on at the time, if this was drug related or something. But yeah, it was just really odd. I've not seen something like this. Like if we look at the bases here, you can see she didn't really have any disease there, but now she's got some dilated airways. So I presume maybe it was incompletely treated, or maybe it wasn't an eosinophilic pneumonia. It was more of an organizing pneumonia and was inadequately treated and somehow left residual. I'm just surprised she's not really having problems with it, given there's still a fair amount of disease. And I couldn't find any connective tissue disease, any exposures. I mean, you can see the rest of the chest is very normal looking. It's just a really odd pattern. So I don't know what to do with it, but it's not broken. So I guess we'll leave it alone. Now this is a very interesting case. I like this one. This is something I don't recall seeing. So this is a patient who is older in his 60s. He is a lifetime non-smoker. As far as I know, has no exposures and has mild emphysema, paraseptal, and at this time at presentation had a probable UIP pattern of fibrosis. There's traction bronchiectasis. It's subpleural basal predominant. So we do see IPF in non-smokers, but the paraseptal emphysema is a little odd. Now we jump ahead 7 years. So already he's lasting a lot longer than your typical CPF CPFE patient, and look at these subpleural bullae here, this paraseptal emphysema, and you can see his fibrosis has definitely progressed. But I've just not seen a case of CPFE, or whatever we want to call it, emphysema and UIP in a never smoker. I've seen plenty of IPF, and I've occasionally seen some paraseptal emphysema in never smokers, but I've never seen the two go together. And considering smoking is a risk factor for both of them independently, it's just very strange. Have any of you ever come across this?
Dilated before?
I'm sorry?
He's got all this tracheal dilation. Was that there on the earlier scan?
I don't believe so. It was generous, but looks more normal there. You're right. It has that more of that sort of accordion look, that with the extra fold there. So like a Meunier-Kuhn type appearance. Yeah, you see the bronchiectasis there too.
Yeah.
I'll bet you there's an underlying autoimmune disease here. I wouldn't be surprised if he has RA or something.
Yeah, I mean, he got a rheumatology workup and didn't find anything. I mean, they're calling him IPF.
I don't think that explains the whole thing. I don't think that does justice to the paraseptal emphysema component.
I don't know.
No, it's very odd for that.
Vasilios, have you ever seen patients with IPF and emphysema who weren't smokers?
Well, usually they have an exposure compatible with hypersensitivity pneumonitis.
Mm-hmm.
Yeah, or maybe in cases with the RILD, with rheumatoid arthritis, maybe they tend to form this pseudo honeycombing with this blobs of cysts.
Yeah, maybe he is an undiagnosed connective tissue disease. I guess it's possible someone gets labeled early on as IPF 10 years ago, and it just sticks and nobody works up. And maybe at the time the rheumatoid workup was negative, but I wonder if we tested him now with an anti-CCP, if it would show up.
Yeah, diagnoses tend to stick. In my experience, people don't often enough revisit initial diagnoses when things later seem odd.
Yeah.
To
Well,
think of something else.
I think that's why the ATS and Fleischner say you can give a provisional diagnosis of IPF and come back and revisit it when more data come available, or the patient declares something different. So,
yeah, I think it's part of psychological. It can be a strong psychological phenomenon and bias, the reluctance to visit a diagnosis that doesn't seem to fit.
yeah.
And new things evolve.
And clinically, he's not acting like a CPFE because he's not. I mean, he's progressed, but over close to 9 years or so. Whatever was the time frames between these two, 7 years or so, which is double the mean survival for IPF. And usually, patients with combined emphysema do poorly. More do worse and they develop pulmonary hypertension, which I don't believe he has any pulmonary hypertension. But David's point is nice. You can see this sort of corrugated look to the trachea that sort of was subtle before, but it's definitely evolved over time. So sort of a Meunier-Kuhn, not necessarily by diameter, but definitely by these little outpouchings here. So that's probably not helping his respiratory functioning. I would not be surprised if we did expiratory imaging if there was some redundant collapse. Okay.
So, Jeff, could I make a comment about your first case with the pneumocystis?
Absolutely.
We looked at a bunch of solid tumor patients because it was said that pneumocystis was extremely rare in people with chemotherapy patients who had solid tumors, as opposed to, say, leukemics and people with lymphoma. And what we found was that all it takes is lymphopenia. So it's just like HIV. If you're lymphopenic, then you're susceptible to pneumocystis. So I'll bet you your patient was lymphopenic. So
I'm guessing
and the steroid,
correct.
The steroid will neutralize your white blood cells too.
I bet those corticosteroids were the contributing factor on top of it. Because I mean, I think of all the patients we see on chemo, and I recall a handful that developed pneumocystis.
Yeah. I've seen it a lot of times in people on steroids, as you say, and I don't know what their lymphocyte counts were.
Yeah. And he was on a high dose taper for at least a couple of weeks. And if I recall, it typically takes at least 2 weeks of high dose steroids to sort of start putting you at risk for pneumocystis. Okay, well, that's good to know, David. Thank you. All right, well, it is the hour, so great cases today, everyone, and I'll talk to you next week.
Thanks,
Bye,
everyone.
Thank you.